My objective is to synergize the wisdom of academics with the community message of Man vs. Prostate to prepare for change. The time is now for BPH BPO care to prioritize bladder health. BPH drugs temporize symptoms so we can triage and obtain bladder health baselines to deobstruct earlier within the window of curability to prevent late-stage disease. My promise is that together we can affect positive change away from a prostate-centric approach to a data-first, pro-diagnostic, bladder-centric paradigm where all of our patients can live their best lives incontinence-free and catheter-free. Let us be the change that saves more bladders. Special gratitude toward these organizers and leaders who help us remember that we are more than drug prescribing doctors, for we are defenders of the detruser who uphold our mandates of preserving bladder health, ending the polypharmacy epidemic, and preventing late-stage disease. And we profess an undeniable truth that along with the brain, the bladder is the only other major organ that cannot be transplanted. We fight on the battlefield of male LUTs, where bladder dysfunction sits at the very center, and we stand guard against the dangers of BPO, ever vigilant of other causes like aging. We commit to the battle plan with an evaluation to counsel, triage with a bladder health baseline if needed, enabling surgical choice where we blend the trifecta of prostate size, prostate shape, and detruser function with shared decision-making 3.0, where the bladder has a seat at the table as an equal stakeholder. And diagnostics serves as its translator to ensure that its preferences and values are heard and integrated into management choices because it has an impact on health span, the number of years lived with good health. More importantly, we submit on bladder span, the number of years with optimal detruser function, because bladder health supports our freedom to thrive. Do not forget, BPO is a progressive disease. Trust the truth of trabeculation, cellules, and diverticuli as evidence of the underlying cellular destruction as BPO progresses to detruser underactivity. We remember that the bladder can withstand this assault only for so much before reaching a breaking point, as we see in this Kaplan study, 50,000 pressure flow studies that show and confirm our suspicions that as men get older, that prostate grows tighter and the flow will start to decrease. The bladder then compensates with rising pressures up to about an age of 62, after which it begins to fail and decompensate. Using these criteria of a missed indication age of 45 and a Qmax less than 10, we see this window of curability appear, which prompts us to ask, how do we intervene earlier, before the onset of damage or before the damage is irreversible? To optimize bladder span, we need to consider these patient scenarios which also affect the bladder. And it's more than just a slowing of flow. It's the anxiety of urgency and frequency, the exhaustion of nocturia, the shame of incontinence, the terror of retention, and the despair of a dying bladder. To simplify the complexity of male LUTs, a linguistic framework is needed. Thus, Man vs. Prostate's 5 stages of bladder health, a community-based, patient-facing decision-making aid, because BPH is about bladder health. The heart is a muscle that pumps blood. The bladder is a muscle that pumps urine through the prostate that starts off about the size of a golf ball but in the shape of a donut. As the man gets older, the prostate gets bigger and the donut hole grows tighter, causing things to slow down, stage 1. The bladder muscle then begins to work harder, quivers, causing overactive bladder, stage 2. If we don't take care of this, the bladder acts out like a rebellious child, contracts without permission, causing urgency incontinence, stage 3. If we really don't take care of it, just like the heart can have a heart attack, the bladder can suddenly stop working, causing the emergency of retention. And like the heart can go into heart failure, the bladder can go into bladder failure, causing a lifetime of catheters, stage 5. Worst case scenario, the heart can still always be transplanted. The bladder does not have this option. And yes, this is an oversimplification. The transitions are not distinct. Stages can be skipped and stages can coexist. Yet it highlights how this disease can steadily progress to more serious stages, and that our top priority is to prevent patients from needlessly progressing to these later stages. As we see in this Thomas study, where the decision was made to simply observe these obstructed patients on multi-channel up to 24 years. And it showed that the consequences were far more than just a decrease in flow and a decrease in contractility, because the real ramifications were on bladder health. Stage 2, detrusor overactivity increased by 100%. Stage 3, urgency incontinence increased by 50%. And now 7 men have been progressed to stage 4 retention when there were none before. The Flanagan study, randomizing patients to watchful waiting in immediate TURP, asking the question, does the decision to intervene matter? And it confirmed our suspicions when we saw the failure rate double with watchful waiting. With the treatment failure going from 28 to 58, we see that the deeper consequences of disease progression are where stage 1 and 2 went from 1 to 13, and stage 3 incontinence doubled, stage 4 and 5 nearly quintupled. So yes, the decision to intervene matters. More importantly, the timing of intervention also matters. And we see that in this third cohort with 27% who underwent delayed TURP in the observed group. They did not fare as well as the immediate TURPs. The upstream trial highlighted the importance of preoperative urodynamics and its impact on deobstruction, and identified who was the most suitable candidates for deobstruction. And it was not those with stage 5 with weakened bladders. It was not those in stage 2 or 3 with overactive bladders. It was those in stage 1 with clear obstruction, where we had the highest chances of rescuing these bladders before there's irreversible damage, unlike what we see on the other end of the spectrum in stage 5. This Mitchell study, looking at a subset of 19 patients with atonic bladders. While maximum deobstruction with enucleation was able to salvage some contractility in the majority, we were too late for 21%, 1 in 5. These data underscore a painful truth. This is preventable. If only we had intervened sooner. And we can. We can do bladder health screening for men starting at the ages of 45 to 55, with Qmax being the next vital sign. We can use the triangle of triage to identify bladders at risk for dysfunction when they meet these criteria in isolation or in combination. Stage 3, urgency incontinence. Stage 4, spontaneous retention. IPSS 8 and above alone, or in combination with slow flow, thickened bladders, high residuals, or unacceptable risk on bphtool.com. These data trigger bladder health baselines with a minimum of cystoscopy up to a maximum of multi-channel urodynamics. The other truth we need to embrace is that BPH drugs are not treating therapies for BPO. They are temporizing measures that buy us time to triage. We are not anti-drug. Just like in sepsis, drugs like antibiotics can be treating. Similar to brain tumors, where drugs are temporizing and surgery is treating, deobstruction is the mechanical solution for the mechanical problem of BPO. And this change in perspective about BPH drugs is not just something we want, it's what patients want. 2/3 of men are not satisfied. 2/3 of men want an alternative because of side effects, cost, inconvenience, marginal improvement. But what about the evidence-based combat trial? We applaud how combination drugs do a great job of temporizing symptoms, reducing the risk by 66% out to 4 years compared to tamsulosin. With that said, inductive reasoning out to 10 years shows that the risk is never eliminated. 1 in 10 combination, 1 in 3 tamsulosin are still at risk for stage 4 retention and surgery. BPH drugs are simply sweeping the problem under the rug as we sidestep the issue to deal with it later when the disease has progressed even further. As we see in this young study where drugs are jeopardizing bladder span as they look at these TURP patients over these 2 decades, with patients on drugs increasing to 43%, we see a decrease in surgery by 65%. Early on, 2/3 of patients are having surgery for early stage LUTS. By 2010, we see this alarming shift to now 2/3 are having surgery for late stage retention. Of more concern is the 6-fold increase in failure to void despite deobstruction, suggestive of late stage 5. So, defend the detruser. If you prescribe drugs, choose data to triage and deobstruct earlier. Stopping this assault on bladder starts with shared decision-making using symptom scores. One size does not fit all. IPSS, widely used. The Learn with question about incontinence. ICIQ, comprehensive with a question about retention. Use these academic questionnaires based on symptoms. In support of academics, Man vs. Prostate launched a communication tool based on bladder health. Single page, designed for community urologists, the bladder was included in the title to ensure its preferences and values were considered. The IPSS and quality of life questions were kept and left 100% the same, and simply reordered with the voiding subscore questions for stage 1 BPO, then the storage subscore questions for stage 2 OAB. The total IBPSS score is identical to the IPSS for continued comparative academic research. 2 more questions, one on urgency incontinence, as well as from retention for ICIQ. This vertical layout mirrors the horizontal stages, empowering patients to auto-diagnose where they are now in the present and where they can end up in the future, igniting them to take action to protect their bladders. One more question about sexual health as well. In the last month, have you had ejaculation and/or erection problems? Now translated into 9 languages, the IBPSS is something to consider as you build your data-first, pro-diagnostic, bladder-centric paradigm, and as Man vs. Prostate supports you with free access to our ebook, the IBPSS, these educational videos. Dive deeper with LinkedIn, our manifesto on Amazon, as well as our recent review. To conclude, you are the future. Be the change that we all seek. Choose data over drugs. If you prescribe drugs, then triage to obtain bladder health baselines, to deobstruct earlier within that window of curability, to preserve bladder health, and to extend bladder span. Make our vision a reality of all of our patients living their best lives incontinence-free and catheter-free as we prevent late-stage disease for this amazing non-transplantable organ. So lean into protecting bladders. We are defenders of the detruser, and let's go save more bladders. This concludes what I have to say. I just wish to add that sharing this time with you is exciting and hopeful. You are the future, and I look forward to similar interactions frequently in the future.